So our objectives today, we'll learn about what a speech pathologist does, also learn how aphasia and neurological disorders impact people's lives, and finally, we'll talk about how individuals are treated by the speech-language pathologist. Am I loud enough? Okay. All right, good. So next, okay, so suppose your doctor comes and they tell you, you know what, there's something wrong with your swallowing, you need to see a speech-language pathologist. Okay, sometimes people are like, speech-language what? So you probably have a lot of questions about that. So Brittany's going to show you a video that we went out and asked people what they thought what a speech-language pathologist does and what do they do.
Training here with SFS therapies, and I'm going to go into Office Depot right now and see if people really know what a speech-language pathologist does. Let's see what a pathologist does. So what do you think a speech-language pathologist is? What do you think a speech-language pathologist is? What do you think a speech-language pathologist is? Speech-language pathologist is.
A speech-language pathologist.
Okay. You know, what do you think is
Every area needs rehabilitation.
okay. So like listening. Okay.
Someone that helps restore language.
Okay. In what ways?
Like, I don't know, someone that probably helps people communicate better.
Analyze the speech language for pathologists.
Okay. All right. I like it.
So do any of you know what a speech-language pathologist is? And I'm going to use the term SLP because it's much easier to say instead of speech-language pathologist. So does anyone know here? Yes.
I sort of do. My wife's one.
Oh, great. So then you have some personal experience with that. Okay.
But I was surprised what they do cover when I met her, because it's just mind-boggling.
Yes, it is. In fact, we're going to discuss that right now. So what is a speech-language pathologist? SLP. We are a highly trained individual, and we work to prevent, assess, diagnose, and treat people who have speech, language, delays with their voice, problems with their voice, problems with their swallowing, and cognitive communication. Okay? Speech-language pathologists work in a variety of settings: hospitals, skilled nursing facilities, private clinics, in schools, and I don't know if any of you are aware of this now, we're moving more towards doing teletherapy, so those services will be available to people who live like in outlying areas like Pahrump and Eli, you guys out there, okay? But that depends on insurance coverage, so don't quote me or anything. It's not something you can go and ask your speech pathologist, hey, I want teletherapy. You either have to pay cash or else it has to be covered by your insurance. Okay, so next slide. Okay, so what do we treat? So that one guy said we treat S's. Well, they're right, we do treat S's. So we work with speech disorders, producing sounds correctly, specifically people who have dysarthria or apraxia, that's related to aphasia, fluency, also known as stuttering. And we also work on voice. So generally the population I work with is people with Parkinson's or MS. So we work on their vocal quality, pitch, loudness, or duration. And then we also work on resonance, okay? And this is for singers, all right? Very few SLPs are trained on that, so I think there's one individual in town who does it here. Next slide. So what do SLPs treat? We also treat language disorders, so receptive, understanding, and expressive. And we work with expressive with either spoken or written, okay? We also work with cognitive communication disorders, and that would be memory, attention, planning and organization, and reasoning and or problem solving, all right? And we see a lot of that with our patients who either have aphasia or else neurological diseases. Hey. Okay. We also work with swallowing disorders. How many of you people knew that? Okay, a couple of you. All right. So we treat swallowing, feeding difficulties due to neurological disorders as a result of a surgery, as a result of a stroke, someone who's experienced a head injury, and cancer. Okay. I'll go back for a second, hold on. This would be an example of when we do a swallowing test with somebody. It's called an MBS, a modified barium swallow, and this would be the side view. Actually, the liquid going down, and actually it's going down into the esophagus, so that's pretty fascinating. What we want to make sure is that your liquid's not going into your lungs, which would cause what's called aspiration, which can cause pneumonia, and then you're a goner. So. Okay, SLPs, we also provide oral rehabilitation for individuals who are deaf and hard of hearing. That is one of my specialties. And we also provide training on the use of augmentative alternative communication. That would be teaching somebody how to use an assistive device. Oh, the pictures are not showing up. Yeah. It'd be like someone who, like this gentleman right here, he's using a Tobii Dynavox, and he's not physically using his hands because he's not able to. What he's doing is he's using his eyes, his eyes control the screen. Okay, so technology has come that far, allowing people with his severity, physical severity, okay, because cognitively he's probably okay, to be able to communicate. And he can communicate anything he wants just by using his eyes, okay? This is the most important aspect. The caregivers being involved with therapy, okay? Family caregivers play an important role in their loved one's progress. Part of our therapy time is devoted to supporting them, teaching them about what the plan is, and ensuring that they're following through with the plan at home, okay? And then finally, they're instrumental in how long their loved one or the person they're caring for stays in services, okay? And next, a big thing that we do with our caregivers is educating and kind of like letting them know with aphasia, this is what you can expect your loved one to be doing. This is what you need to do to help them communicate better. We also provide support and guidance with stress-related, I don't want to say disorders, but I guess stress-related disorders, because the fact that they're taking care of somebody who has a lot of needs physically and mentally, it taxes them. So they need some sort of support or somebody to speak to. Sometimes it's just one person who's taking care of somebody, let's say with MS, and they're at the later stage. That's a lot of work, and it can, cause a lot of problems. So, and we also, as SLPs, we provide those resources. We let them know in the community where they can find support, either in the community or also on the web. So now we're going to talk about aphasia, okay? So aphasia, okay, here are some facts. There are 2 million people who are affected by aphasia per year. That's per year, 2 million people, that's a lot. And we're talking about people from mild to severe. Aphasia is not a disease, okay? It's a symptom of brain damage that also results from either a stroke, a head injury, which is TBI, cancer of the head or neck, and or could be a neurological disease. Okay. Oh, let's see. Is my text going to show up here?
Yes.
Here? Okay, good. Okay. So here we have, these are the areas of the brain that are responsible for language and communication. So it's the left side of the brain, okay? So left side of the brain, and we have Broca's area that's more kind of like right here. And then we have Wernicke's area, and it's maybe right about here, okay? Broca's area is in charge of the production of coherent speech and language, okay? If damaged, there's a loss of ability to produce language, and most of the time the parents are aware of the challenges. So typically this is called non-fluent, okay? So Broca's is non-fluent. What happens is this is a perfect example of someone with Broca's aphasia. Dad, store, banana, okay? So most of the time they just use like nouns and verbs. So dad, store, banana. Dad took me to the store and bought a banana for me. Okay, that would basically be it. So we kind of call that like telegraphic speech. So they understand and know what they want to say, but they're not able to express it the way that people normally do. Okay, so yes.
Are they unable to express it because they can't find the words, or they can't form the words?
It could be two things. It could be that they can't find the words, or else they can't form the words. Because remember earlier I told you about speech production. Sometimes when someone has aphasia, they could have either dysarthria, and this is dysarthria would be like they kind of sound like they're drunk, because it's muscle weakness, as opposed to apraxia would be, I want to say dog, but by the time the message comes from here down to my articulators, they say frog, frog, frog. Okay, that would be the difference. Okay, I can answer some questions later on about dysarthria and apraxia, because actually I can do a whole presentation on that. Okay, so Wernicke's. This is the area for processing of speech and language. Okay, so understanding speech and language. And if damaged, they'll have fluent speech, but you won't have any idea what they're saying. So they'll say the dog is, like, if you ask me a question like, what time are you going to the store? I say, well, the dog is running. Are you going to go? Bree? Yeah? D? B? That would be an example of Wernicke's aphasia, okay? So most of the time, the individual is unaware that they're having difficulty, okay? They have no idea. That's why when you're speaking to them, they're acting like what I'm telling you is like, don't you understand me? Yeah, that is interesting. It's interesting to see people who demonstrate Wernicke's. Okay, so next slide. Okay, when a person has a stroke or neurological disorder or any other injury, it generally disrupts their ability to use or to understand language. Okay, so through language we communicate our inner thoughts, our feelings, our desires, intentions, motivations. Through language we understand what people say to us. We are able to ask questions, we're able to give commands, we're able to comment and interchange, we're able to listen, read, write, and use gestures. Okay? This is an example of two types of strokes that you can have that'll cause aphasia. We have the ischemic, that's where you either have a blood clot or a piece of plaque that goes up to the brain, stops the blood flow to that area of the brain, or else you have hemorrhagic, and that one is where the blood vessel just bursts. You don't want that one, so. Next slide. Okay, ischemic strokes, about 87% of the time these strokes occur, it's ischemic. Next slide. So back to aphasia. There are different types of aphasia, and you can see them all listed at the bottom, all right? And just to give you a little background on some, we already spoke about Broca's aphasia and Wernicke's aphasia. Well, some of them are more severe than others, and global aphasia would be the most severe. That would be where you are not able to communicate and you have very little understanding of what's going on, okay? Someone like anomic, right here, that's more like word finding, and it's the most mildest form of aphasia, but what happens is people have a problem. You show them a picture of a dog and you say, what's that? And they won't even know. You show them a picture of a family member and you'll say, who is that? And they won't know, they either won't know or won't remember or won't be able to recall that that is their mom, okay? So next slide. Okay, there's different severity levels of aphasia, all right? And they go from either mild to severe. And if you go back to the other slide. So each one of these aphasias here can be very mild, in their form, or else they can be very severe. And that kind of plays a role in how much progress they're going to make through therapy and over the course of time, okay? So this is an example of a left side stroke. Typically, remember, left side, most people have left side strokes, okay, because of language. Speech and language abilities are often found in the left side of the brain. They experience speech and language deficits, okay? So they may have problems with speaking, listening, reading, writing, dealing with numbers, okay? Understanding speech and thinking of words when talking or writing, okay? And most of the time that would be called like word finding or word recall, okay, or word retrieval. Right side stroke, I like Picasso, so these are pictures for Picasso. Aside from having speech and language challenges, they'll have cognitive challenges, okay, for the right side. And go on. So some experience what's called left neglect. Does anyone here know what left neglect is? Okay, I'll explain in a second. And they'll experience anomia, not recognizing faces or pictures of familiar people. And they'll also have problems with having denial. They'll deny that there's even a problem, okay? And limited attention. Okay, and that plays a big part in when you're providing therapy, when someone, number one, denies that they even have a problem, and two, that they have limited attention, because you need attention to be able to focus and to learn, to acquire information. If you can't, well then you're not going to receive any sort of benefit. So the next slide is left neglect. This affects the visual field. So what happens is the individual is asked to copy these pictures right here, but this is what they actually see. Why? Because with left neglect, if you're going to split your eyes, you need both eyes to see. And with both eyes, what I'm doing is this part of the vision field on each eye, 1/2 of each eye is basically useless. So what happens is when we read from what? From left to right. So what happens is when they look at a book, they don't see this part. They only see the right half of the page, okay? So what we do in training, if their attention is good enough, is we remind them to look left to right, left to right. And that not only affects individuals with aphasia in reading, but affects them in their life in general. Because can you imagine if you have no idea that someone is to the left of you? You might see a little bit of them after a certain, maybe right here, but then that would be it, okay? So, aphasia. Okay, another thing that can cause aphasia are brain tumors, and that really depends on what part of the brain the tumor's in. I haven't seen very many patients with brain tumors, but the few that I've seen, their challenges have been pretty significant. Next one. Another thing that causes aphasia is head injury, okay? And that's very common. I will tell you right now, in my clinic, in the past year, I have seen about a little over 20 males between the ages of 18 and 24, all of them from TBI, all of them from doing silly things. So, and this is an example of head injury with traumatic brain injury. And what happens is, and I'm sure a lot of people know this already, but the brain kind of bounces back and forth in the head. What's interesting, and I'll let you know this, is if you know someone who has a head injury, they're in a car accident, and they're telling you that they're okay, that they're fine, please ask them to go to the hospital and ask for MRI, okay? Because you want some documentation there to let people, to show that if there are problems later on. And it doesn't always show up on an MRI or a CAT scan, because sometimes the tearing of the neurons can be so like minute that it won't be picked up, all right? Okay, next slide. Aphasia as a result of a TBI, they can have sensory problems, they can have behavioral problems, their personalities will change. They'll have cognitive deficiencies. A lot of the times it'll be with sequencing and memory recall. communication deficits, and then finally swallowing. They might even have problems with their swallowing, okay? So progressive neurodegenerative disorders, okay? So what are neurological disorders, all right? They're diseases of the brain, spine, or the nerves that connect them, all right? Progressive neurological diseases and disorders, individuals will experience progressive deterioration in their speech and communication functioning, and also with their swallowing, all right? It impacts the individual for their life, and it also impacts their caregivers too, because there's a lot of care that's needed. Some of the progressive neurological diseases are Parkinson's, multiple sclerosis. This motor neuron disease is amyotrophic lateral sclerosis, that's a mouthful, and or progressive bulbar palsy and dementia, okay? So all of these diseases and disorders will experience aphasia as well, okay? So we're gonna continue on. So Parkinson's disease, it's a movement disorder. We all know the classic signs of Parkinson's disease, maybe the tremor in the hand, leaning over the gait, the shuffling, there's no movement in the arms, okay? So with Parkinson's, with speech language pathologists, is the muscles in the face, mouth, and throat are used for speaking and swallowing, and those are impacted, okay? Changes with communication and swallowing vary from person to person, all right? So I've seen some patients with Parkinson's who have very mild symptoms, okay? And then I have others who are pretty severe, all right? So symptoms with Parkinson's disease is the soft voice. So they actually kind of like talk like this, but they think they're talking like this. So most of the time they think that they're yelling and screaming when actually they're just kind of talking like this. They might have slurred speech. That's dysarthria, remember that. They may mumble, or they might have really rapid speech. So some of my clients during therapy, when we're doing voice training, I have to ask them to slow down because they'll be really speaking really fast, just like this and everything like that, and I just can't tell them to I can't understand them. So, monotone. Some patients will demonstrate speaking like this. They just kind of talk like this, and I don't really know if they're excited, if they're happy. So you happy you had your birthday party yesterday? Yes, I'm happy. Just like that, okay? Breathy or hoarse vocal quality, and there's a lot of, most of the time, later in, further on down the line with Parkinson's is there's a lack of facial gestures. And they might also experience word finding difficulty, and then challenges with participating in a fast-paced conversation. And finally, they'll have problems with feeding. So they'll experience a lot of choking and coughing, okay? Also with Parkinson's disease is, I was telling you about the masked face, okay? So a lot of people misinterpret or don't understand the person with Parkinson's because they see most of the time their facial expression is like this. And sometimes people think, well, either not interested in what I'm saying, or else they're bored, or else they don't care. And I've seen people actually get upset with individual because they don't understand that they have no idea that their face is showing, get away fly, no expression at all, okay? So what we do in therapy is we train them in front of the mirror to be aware of that, okay? But what happens is they tend to forget that. So that's the same thing with their voice. They're thinking that they're speaking louder when really they're kind of speaking like this. So we have to cue them and give them cues on how to use their voice with like more intent, okay? Multiple sclerosis, okay? This happens when the immune system your immune system attacks the fatty tissue, the myelin, around your nerves. And once that fatty tissue is kind of taken away, the nerves aren't able to send the message from one part of the brain to the other effectively. And that's where you have problems with balance, movement, picking up things, strength, and then it also starts to affect their speech and swallowing, okay? Without this outer shell, your nerves become damaged, so scar tissue may form. And just like I said, the damage means that your brain can't segment signals to the required area, okay? Multiple sclerosis, okay, this is a long-lasting disease. So there are some people who do not demonstrate any symptoms for years, and then all of a sudden will have a whole cluster of them within a couple of months. There are some people that just go through a progression, okay? Some of the long-lasting or the affecting, some of the disease affects the brain, spinal cord, vision, balance, muscle control, and other basic body functions such as speaking and swallowing, all right?
Do all individuals that have MS eventually develop aphasia or speech?
No,
issues,
no.
or-
I have seen very little people with MS develop aphasia, but I have seen them develop problems with dysarthria because of the muscle weakness, because they're not able to articulate like they used to, because it's basically your body is like, as one patient said, my body's betraying me. So it's like it's giving up on me. I don't have the strength that I used to. So they end up sounding like they're drunk. They might have problems. I see their problems with vision. Most of the patients I've seen have been in motorized wheelchairs, and they'll have problems with swallowing. Yeah.
So with what you do, are you able to teach them ways to compensate, or
Yeah.
how does that?
Yes, and we're going to talk about that later, but I will address that now. Well, with dysarthria, with speech, what we end up doing is we give them exercises, we do drills, teaching them how to use either, depending how severe the dysarthria is. So if it's real mild, it's mostly getting them to pay attention to slowing down, articulating, not rushing through speech. To as the disease progresses or dysarthria gets worse, they work on possibly using common phrases, or in my case, with about 8 or 9 of my patients, we moved over to augmentative devices where they actually started using the eye gaze because their speech was so unintelligible. And like one gentleman I had, his speech was so unintelligible and he was just drooling all the time. He was just a really smart guy. And we got him set up on the eye gaze, and it was just like a whole new world opened up for him. Okay. Next, so multiple sclerosis, swallowing, just like I said. People often have a difficult time with swallowing, and just to answer the question, swallowing therapy just depends on the severity, how severe their MS is or aphasia. So it just really depends. I can't answer it. It's something you just kind of deal with each patient. Here's something that's interesting, okay? If you're unable to swallow properly, when you look at this area right here is your esophagus, okay? That's where the food should go down, okay, into your stomach. This area right here, this is the trachea, okay? This goes down to the lungs. We don't want any food to go down here, because if you do, you can, we call aspiration. And if you have aspiration, you can get pneumonia or anything like that. And most of the time, people are in a weakened state already, and fighting off pneumonia is a lot of work. So here it is, our food. We want our food to go down the esophagus. Through therapy, we train and teach them exercises to strengthen the larynx and the pharynx. And we teach them compensatory strategies and ways in which they're supposed to eat. And sometimes they have to have caregivers, feed them if they're not able to lift up their arm at that point. We have, and I'm kind of getting ahead of myself, if they have problems with not being able to get enough nutrition in, sometimes they have to be put on a G-tube. And a G-tube is where you're fed through the stomach, okay? They just make a little hole, incision into the stomach. And also dehydration. A lot of patients end up becoming dehydrated because they're not getting enough nutrition, all right? So multiple sclerosis speech, I kind of touched upon this with somebody who has dysarthria. it's very hard for people to understand them, especially as in the later stages of the disease, where they're kind of like this. They think they're telling you that they went to the movies yesterday, and you're say that again. Movies. Okay. So the muscles, their tongue, their jaw, everything around here becomes weaker. And that's why, because they're all muscles. Everything is muscles around there. Okay, so let's go through. I kind of answered all these. Oh, one of the most common complaints these people have is they will say that they're slurring their words. Other people will say that they sound like they're drunk. They'll have trouble changing the tone of voice, and they'll have like a nasal quality because the upper, you have the hard palate, and right behind the hard palate is your soft palate. That's like that flappy skin, you know, where the uvula is. So as the muscles become weaker, they're not able to keep it up. So you get that kind of like nasal voice like this. I do want to tell you, one of my patients last year, I always encourage him to get ID bracelets and stuff like that. And he had pretty severe dysarthria at this time. He didn't have MS, but he had dysarthria. And he was driving, got stopped by a cop. He tried to tell the cop what was going on. Cop would not listen. He was arrested. They thought he was drunk because he didn't have good balance, so he didn't pass the test. And he spent about, I think about 12 hours in jail before his wife picked him up. So, any of you who are dealing with a neurological disease or aphasia or anything like that, and if it is something like dysarthria, regardless, you should get some sort of ID bracelet for your loved one. And it's a typical ID bracelet. You put their name, whatever their disease or disorder is, and a contact number. That's all you need. And if the police see that, then they'll know what to do. Because that's unfortunate that he had to experience that. So, motor neuron diseases. The amyotrophic lateral sclerosis, I love that word. That's also known as Lou Gehrig's disease. And that's a progressive brain disease that attacks the nerve cells that control the muscles, all right? And it's a gradual degeneration, okay? So the signs and symptoms of ALS depend on the muscle groups affected. Earliest symptoms might include there's a muscle twitching like in your arm. Your muscles might experience some stiffness or tightness to them for no reason at all. You kind of feel weak. Start to experience slurred speech, and then difficulty with chewing and swallowing, okay? ALS is a the degeneration of the motor neurons in the brainstem, and we're going to talk just briefly about bulbar ALS, and it affects the individual's ability to speak loudly and clearly with dysarthria. And I kind of touched upon this before, but as someone progresses through this disease or MS, they'll start with real mild symptoms. So occasionally they'll kind of slip up on words or they'll say it a little distorted. But as the disease moves on, they'll become even more unintelligible. And then they'll find that more people are like saying, what? What did you say? Or can you say that again? To the point where they're unintelligible to most people, where they need some other form to be able to communicate, okay? And if most of the time they have the cognitive abilities left, so they can, most of the time they can't write, they'll end up going with an assistive device, okay? And the speech language pathologist works with companies like Toby and Dynavox to set up and train them how to use these devices so they're able to communicate and participate with their loved ones, going to the doctor. You know, there's nothing worse than the doctor asking the patient what's going on, and the patient has trouble conveying it to the doctor, and they're expecting the loved one to know what they're saying. That's impossible. And it happens quite a bit. So next. This is the same progression from where they start having problems. People with ALS, they'll start to notice that, wow, whenever I'm eating solid foods like steak and I'm chewing it, it's getting difficult to chew it. And then when I swallow it, I either feel like a lump in my throat or I start to cough. There's more throat clearing afterwards. Those are all signs of possible aspiration or penetration. And as the consistencies become softer, as the disease progresses, even drinking water becomes dangerous because first, they just cannot control the water going back into their esophagus. People with ALS tire easily, so there's little energy to eat, and eventually they just don't enjoy eating. And if any of you have ever been sick or so weak that you're like, "Oh, I'm just not hungry, I just don't feel like it," multiply that 100 times. This is what these people end up experiencing every day. So there's no enjoyment in eating. And I'll tell you one thing, I love to eat. You can tell. So I love to eat, and if anything, most of the complaints I have from people with ALS or MS or Parkinson's is when they're told that they have to go on a modified diet, that they have to eat a different texture of food because if they eat something solid, they can choke to death on it. You're telling them they have to have parade, and that's where the food is just blended. Most of the time, these people don't want to eat like that. They're like, I don't want to eat like that. I'm just going to eat what I want. And that's another story. So these people, when they have problems with eating, it's difficult to maintain their weight. And if that is the case and they're having problems with losing weight, they're not getting enough nutrition, then we work with gastro and they work on inserting a feeding tube, okay? So dementia, this is the last one here. Dementia is not a specific disease, okay? It's an overall term that describes a wide range of symptoms associated with a decline in memory or other thinking, okay, skills, and is severe enough to interrupt that person's ability to perform ADLs. And ADLs, if you are not aware, they're activities of daily living. And these are the things that we do every day. Grooming, bathing, managing our medications, managing our finances, using the phone, shopping, cooking, house cleaning. Those are all activities of daily living. And we need our cognitive abilities and our physical abilities to be able to perform them. If one is not working, then that kind of hinders or impacts the amount of participation we can be in every day with activities, okay? So dementia is a progressive illness. I don't know if any of you know anybody who has any symptoms or is experiencing dementia. Anybody? Anybody? You guys know? Nobody? So it affects a person's ability to remember and understand basic everyday facts such as names, dates, and places, okay? Dementia, okay, Alzheimer's is the most common form. It's commonly seen after the age of 60. Lewy body's dementia is second in line. Then we have vascular dementia, and that's related to strokes. So people can have multiple strokes and end up developing vascular dementia, okay? And then there's also primary progressive aphasia. And that one has to be the most, I guess the most unfortunate one I've seen as a therapist is I've had people who done opiates and they abused them to the point where they ended up experiencing having primary progressive aphasia. And we're talking about people in their late 40s, early 50s, and there's a fast decline in their cognitive and memory abilities. And it's really tough to see. And it's tough for them to experience because at the beginning, they know something's going on, but as this disease progresses, they need help with almost anything. So, next. Oh, okay, problems to expect, I'm sorry. People with dementia will probably have problems with word finding, and not everyone has the same symptoms, okay? So I'm just kind of giving you kind of a cluster of things that might possibly go on. So they'll also have repetition of familiar words. They'll keep saying ball. They might say ball 100 times, okay? They will lose their train of thought. They'll have problems organizing words logically. They'll just kind of just randomly say things. And my father had dementia, so he would say things to me sometimes, and at the time I didn't know what was going on, and this was years ago, and I'd be like, Dad, what are you talking about? Well, later on I figured out, well, it was because he had dementia. So, and another thing is speaking less often, because they lose the ability to remember things and process language. They kind of like fold in, and they're not as social as they used to be. Okay. Swallowing with dementia is very, very important, because what happens is as they're forgetting how to perform certain things in their life, and forgetting people, and forgetting how to maybe dress or to eat, they're going to have problems with even chewing and swallowing sometimes. Okay, so as dementia progresses, swallowing and chewing problems occur. Here are some of the 6 signs, and this is not only for people with dementia, but okay, there's coughing during or after eating. So they'll start to experience that quite a bit. And when I say after eating, they could be coughing for an hour or 2, or their throat clearing. They're doing that a lot. When they're eating, or when they're swallowing, they're grimacing. So they're going, and that should tell you that they're having problems swallowing maybe hard foods, okay, more solid foods, exaggerated movements of the lips, tongue, and jaw. They'll do literally, they'll do that. They'll be pocketing of food. That's where they chew food and they just keep it in their mouth. The risk to that is they keep it in their mouth, you don't pay attention to them, they go off, and maybe a half an hour later they're probably sitting in their chair, and then the food just falls back into their throat, and they're not ready for it, so they can choke to death, or else they can aspirate, they can get it into their lungs. So that's why people, when they have dementia, or anyone who has a swallowing issue, it's important for a caregiver to be with them if they're at their later stages of having challenges with their swallowing, to make sure that they don't choke, okay, to make sure that they don't aspirate on anything. And most of the time people with dementia will be refusing to swallow, or else to spit out their food, okay? And then there's also overstuffing. Overstuffing and pocketing have to be two of the biggest concerns for me, because with overstuffing, they put in food, they put as much food into their mouth, and what happens is they try to swallow it, okay? And what happens if you try to swallow a bunch of food in your mouth? You're gonna choke, yeah. So next one, dementia. This is kind of like, this kind of knocked me off my feet. Look at that, okay? Here in America, 2 years ago, about 9 million people. 2050, 29 million people are gonna be affected with dementia. That's a lot. Okay, look at the whole world. In 2050, 131 million people. That's a lot of people. So, how can SLPs help? I think I've kind of touched upon it in some way, so I might repeat myself, but the goals of therapy are to help the individual communicate to the best of their abilities, all right? We're trying to restore as much cognitive, language, voice, and swallowing function as possible, all right? And we want to find alternative methods for communication, because the whole point is for that individual to be able to communicate and to function like everybody else, to the best or to the best of their potential at that time. Okay, treatment for aphasia and neurological diseases and disorders. When someone has a stroke, we refer to the process as a rehabilitation process, and it usually involves extensive exercises. It's like kind of doing homework, all right? And where the patient practices techniques and strategies to help with either their delays with communication, language, swallowing, or voice, all right? So for example, just kind of stay there for a second. So like voice, this gentleman right here is working on what's called VisiPitch, and this is to help his voice. It's not really related to people who have Parkinson's, but it's something related to that, where he's probably working on increasing the intensity of his voice. So he's probably speaking like this. So they're trying to get him through drills to keep practicing and keeping his voice at this level. This lady right here, she is going through swallowing therapy. That's called VitalStem, electrotherapy. And they put pads on their cheeks and right here for swallowing. And Vital stem, they propose that exercising the muscle will strengthen it. And there's not enough research, I think, to support it. So I'm kind of like on the fence on whether that's really effective or not. And I don't know what that guy's doing with the lady, so yeah, sorry. So factors that influence the amount of improvement experienced is based upon the cause of the brain damage or the type of neurological disorder, all right? The area of the brain that was damaged or is affected, okay? The extent of the injury, the age and the health of the individual, the educational level, handiness, and overall motivation to improve. So stop there for a second. So when you think about the cause of the brain damage or the type of neurological disorder and disease, remember I told you that people either have very mild forms or else severe forms. So you have to keep that in mind. Not someone who comes in for therapy is like 10 people who have the same type of hearing loss on the audiogram, okay? So 10 people all have the same type of hearing loss on the audiogram. Each one of them is going to develop or benefit from therapy in a different way. Some will make phenomenal gains with their auditory, their speech and language skills, and others will not benefit at all because of their hearing loss. They just don't perceive sound the way that maybe the first two people do. Okay, so it's the same thing. When someone comes in with aphasia or neurological disease, they're all at different stages, different levels, and there's so many variables that we work with that the outcome, there's no way to say what the true outcome will be. Okay, so I can't tell you, and I would never tell anybody that, yeah, that's right, you had a stroke and in 3 weeks you're going to be fine. I would never tell anybody that. Therapy takes time. Therapy takes time, takes commitment, takes some work. All right, next one. Progress in therapy for each person is dependent on the severity of the injury to the brain, mild, moderate, severe. Some patients progress quickly and regain most, if not all, lost skills, and I've seen that before. And some patients' progress may take longer, okay? And by longer meaning not months, but it could be years, okay? And we're talking about a couple years, and I've had some patients where they've come back after, when I first started, one lady came back and she's been, she was basically broke his aphasia. She came back, and her only problem right now is she is still unable to do math computation. That's her only thing. Her language is great, her speech is phenomenal, her understanding, she works in a bank, she can't do anything with numbers, and she works in a bank. That's kind of funny, so, not funny, but, okay. How long does it take them to get better? That depends. Like I just said, months, years, even decades. And I want you to keep this in mind. There's a thing that's called neuroplasticity. The brain is always healing and changing. So it doesn't matter if you're 5 years old or if you're 50 years old, you're still going to make progress, okay? The unfortunate thing is someone who's younger has a better outcome than someone who's older because, you know, we're older and the brain is not as like pliable as it was before, but you're still able to make improvements, okay? Next. Okay. So what do we do for communication and cognitive skills? Okay. Once we assess the person and we devise an intervention, we capitalize on that individual's strengths and their weaknesses, and that affect their communication across everybody, across their partners, their activities, whatever they're doing, okay? We facilitate these activities by teaching them new skills and compensatory strategies to both the individual with aphasia and to his partner. So we're not only working with the patient, we're also working with the partner, teaching them the strategies on what they can do to help facilitate communication at home. And then we modify the contextual factors that serve as a barrier and enhance those that facilitate functional successful communication and participation. Meaning, if we have to teach them how to use larger print, using applications on iPads, which are a big thing now. If you have iPhones, there are hundreds of applications out there that help with reminding you to perform your feeding exercises, keeping you on task.
Dyslexia.
Uh,
It'll blur everything.
Yeah, thank you. And simple applications that'll help you communicate with people on just basic phrases. Like if you go to a restaurant, you say, I want a glass of wine. Okay? So next. Okay, treatment approaches. Treatment can be either compensatory or else restorative. So compensatory is aimed at compensating for deficits not amenable to retraining. Okay, so someone who is not able to develop their speech skills, well, we're going to give you something that's along the same line. So we'll have you use an assistive device that will speak for you. So you'll put in the words or else you'll touch the picture and it'll speak for you. The restorative is aiming at improving and restoring impaired function. That's more like the rehab. This one is more rehab, and that's where someone who has experienced maybe a mild stroke and we're retraining the muscles, strengthening the muscles for swallowing, and the outcome is that they're able to eat a regular diet. By regular diet, meaning that they can eat everything and anything. They can have thin liquids, they can have solids, they can have anything, as opposed to somebody who is put on a parade diet that's everything blended. Yeah, so if you've ever seen spaghetti blended, it's not good. It doesn't taste good. Okay. This is, I was telling you earlier about ADLs. These are some of the ADLs that if you don't have the cognitive ability to remember the steps on how to bathe yourself or how to dress, okay? And I'm not talking about the physical part, I'm talking about the cognitive, like first I need to put my right arm in, then I need to put my left arm in, that sort of stuff. If they're not able to remember that stuff, and this is what we teach them, and strategies how to follow through with sequences, problem solving, you know, like if they're putting on their shirt and their shirt drops. So the problem is how do I bend down and reach over and grab it, okay? So it's all those strategies, because there's some patients who would let the shirt drop and then they'd be like standing there, what do? I don't know how to get the shirt, okay? So how are swallowing disorders diagnosed by the SLP? When someone comes in and they're having problems swallowing, what we do is we take a careful history of the medical conditions and symptoms, and we look at the strengths and movements of the muscles involved in swallowing. We observe feeding to see their posture, their behavior, and oral movements during eating and drinking. And if we need be, we'll perform either 2 different types of swallowing procedures. And I showed you that picture a long time ago, the MBS, that X-ray. We either perform that or else we'll do an endoscopic assessment. And that's where there's a tube that goes in through the nasal cavity and looks right above the vocal cords at swallowing. There are pros and cons to each one. This one is safer because you're not exposing them to radiation like in the first one. But the MBS, the first one, it's not that much radiation, but I don't know, I'd rather do the endoscopic for myself if I had a problem. Okay, treatment depends on the cause, symptoms, and types of swallowing problems. So depending on the outcome of the MBS or endoscopic study, specific swallowing treatments and exercises to improve muscle movements will be developed in a plan, and positions or strategies to help the individual swallow more efficiently, okay? And then specific foods and liquid textures that are easier and safer to swallow. So I'll tell you, I have charts, and if any of you want them, you can put your name down and give me some sort of way to contact you. I have charts, feeding charts, and it gives you different textures and the foods that are available that you're able to eat with each texture. Okay, so if someone is on a modified diet and they have to have nectar liquids or nectar type liquids, that means we would have to add, it's called thicket. So it's like a thickener agent, and you put it into their liquid so it makes it thick like nectar consistency. And I have charts and everything like that. They're a guide like that I give to my patients when we read the MBS and we're telling them this is the plan that you have to follow. Okay, next. That's it. Questions? I have like 3 minutes. Yes?
These procedures are usually based upon one occurrence, a stroke, they had a stroke. But how about the frequency of those type of strokes? Is that a one-time thing, or could this person have more strokes and then have more complications?
You know what? That's a good question. Typically, when someone has their first stroke, their chances of having another stroke increase. I've had individuals where they had a mild stroke for their first one, and then after that, they had a pretty severe one after that. Then I've had some patients where each time they had just a mild stroke, and the first time they didn't have any problems with swallowing, but the second stroke, they ended up having problems with swallowing.
This can also be with hemorrhaging.
Yeah. Anybody else? Yes.
Some of the things you described in, like, saying when you can't dress yourself, how does that differ from having an occupational therapist?
Well, let me clarify that. Occupational therapists work with that, but if you don't have the cognitive ability to be able to process and plan how to do that, then you're going to have problems with being able to dress yourself. So you would have to ask yourself, would that individual benefit from occupational therapy if they're not able to follow simple directions?
So how would you get them to a place where, or will they not be able to follow?
It depends on the individual. I mean, if they have mild cognitive challenges, then the outcome is pretty good. But if the more severe, I guess it would take longer to get to that point where they're able to probably benefit from it.
What would an example of an exercise? I'm just not able to wrap my head around what you would do.
For like what I do?
Yeah, like if you encounter someone who couldn't process the next step in putting their arm in the sleeve.
Well, let me kind of, I'll use cooking as an example, okay? So what we'll do sometimes is we'll, following the steps to how to make a peanut butter and jelly sandwich. So, what do you remember about making a peanut butter and jelly sandwich? Okay, they'll tell me what they remember. Okay, well, here are the ingredients, and let's say we've had a couple of lessons, and now to the point where they're showing me how to do it. If they can't remember that, first I have to take the bread out of the bag, then I have to take the knife, probably unscrew the lid of the peanut butter, that sort of stuff. They can't remember or understand what they have to do first to do something, then that's where they have the challenges. It would be like somebody, there's a test that I give, and they're given 5 or 6 pictures on making pasta. So they have to kind of organize it, sequence it in order, and people with TBI generally are not able to do it. The more severe, so they'll look at it and they won't even have any idea what they're supposed to do. And I'll say, so what's the first thing that you would do here? And I'll start to cue them. I'll say, if you're going to make spaghetti, how would you do this? What would be the first thing that you would do? And they look at the pictures and they can't even do it. So, yeah. Yes, ma'am.
Are there any exercises for comprehension improvement or language improvement for people who do have aphasia?
Yes, there's so many exercises. The most important thing about after you have a stroke is twofold. Number one is you want to challenge an individual, okay, through cognitive activities every day. It could be on the computer, it could be reading activities, them doing crossword puzzles, word searches, doing jigsaw puzzles, any of that stuff that gets their brain thinking. But also with exercise, you have to have time for the brain to kind of like heal and become better. So it doesn't make sense if you're in therapy and you're having them work for 5 or 6 hours in a day and all of a sudden you expect there to be changes. They need a little break. So that's why doing activities and homework, anything like that, they need that break. So I like to advise my patients that when whatever assignments I give them, activities, that they do it for 20 minutes, then they're doing something else, maybe something like helping out in the kitchen for a half an hour, and then they're going back and they're doing the crossword puzzle. Or if they feel like they're watching TV in between the commercials, they can do a word search or they can work on some other activity. But always challenging the brain. But there are plenty of activities, and I can probably answer that question in detail, later on. Anybody else? I know it's time, right?
But if you have other questions, you can just stay behind and ask Mr. B. He'll be able to answer them. So thank you so much for
Thank you.
being here.